This tutorial is going to focus on how to interpret an ECG with a systematic approach. Electrocardiograms are used to give us an idea of the electrical activity of a patient's heart. There are 10 leads in total, made up of 6 chest leads and 4 limb leads, which give us 12 traces. If the electrical activity depolarises towards an electrode, the reading is positive, and if it depolarises away, the reading is negative. There are 2 main types of leads. Bipolar leads measure the potential difference between 2 electrodes. These are in the limbs. Unipolar leads measure the potential difference of an electrode from this central point, which is called Wilson central terminal. And these make up the remainder of ECG electrodes used. It's important to understand the basic waveform of a normal ECG. The P wave represents the depolarisation or contraction of the atria. The PR interval is then the time it takes for this impulse to travel from the atria down through the ventricles. The QRS complex is depolarisation or contraction of the ventricles, and the T wave represents ventricular repolarisation or relaxation. Atrial repolarisation cannot be seen due to the other waves that are present. Now we're going to have a look at a systematic approach to interpret an ECG. First of all, we want to start with the patient's details. We want to make sure it's the correct patient's name and age, and we also want to look at their sex. We then want to look at the date and time that this ECG was taken, because if it was taken at 3 o'clock in the morning and it's now 10 o'clock in the morning, it might not be as useful to the patient's current clinical condition. Also look for a clue. Sometimes ECGs along the top will give you a readout of the machine's interpretation of the ECG, but it's important to still check it yourself. Next, we want to look at rate. Rate is calculated by dividing 300 by the number of large squares between each QRS complex. In this example, there are 4 squares between each QRS complex. Therefore, the rate is approximately 75. If the rate is too fast, usually above 100, this represents a tachycardia. If the normal waveforms can still be seen, such as in the above example, then this is a sinus tachycardia. If, however, there does not appear to be a normal waveform and the below picture is seen, then this is a supraventricular tachycardia. If the rate is too slow, usually below about 50 beats per minute, then this represents a bradycardia. In the below example, the normal waveform can still be seen, so this is a sinus bradycardia. Next, we want to look at the rhythm. This involves looking at the distance between each QRS complex and seeing if this is regular or irregular. A common rhythm abnormality is atrial fibrillation, which is seen when the rhythm is irregularly irregular and there are also absent P waves. Next, we want to look at axis, and for this we look at leads 1 and 2. Both leads 1 and 2 should be positive for the majority of the waveform. Left axis deviation is seen when the lead 1 is positive and lead 2 is negative, and these appear to be leaning away from each other. Right axis deviation occurs when leads are reaching towards each other. This occurs when the lead 1 is negative and lead 2 is positive. Next, we start to analyse the waveform. First, we start with P waves, and there are 2 main questions you want to ask yourself regarding P waves. Are P waves present? And is there a P wave before every QRS complex? Then we want to move on to the PR interval. There should be less than 1 large square between the end of the P wave and the start of the QRS complex. This represents 0.2 seconds. If the PR interval is prolonged, but there is still a P wave before every QRS complex, this represents first degree heart block. If there is progressive prolonging of the PR interval and then a QRS is dropped, this is Mobitz type 1 or Wenke back. If there is no prolonged PR interval, i.e. that PR interval is otherwise normal but a QRS is dropped anyway, then this is Mobitz type 2. And if there is no relationship at all between the P waves and the QRS complexes, this is third degree or complete heart block. Then we want to look at the QRS complex itself. The normal width of it should be about 3 small squares, and its normal height is up to 5 big squares. If there is ventricular tachycardia, we get this rhythm of the QRS complex as being fast, fat, and regular, as depicted in the above ECG. And if there is ventricular fibrillation, then the ECG is fast, the QRSs are fat, i.e. they're broad, and there is an irregular rhythm, and you get this classic pattern as seen in the below ECG. Next, while we're still looking at the QRS, we want to assess for bundle branch block. This is classically described as seeing a W shape in V1 and an M shape in V6 representing left bundle branch block. This can be caused by an MI, hyperkalemia, or hypertension. If there is an M shape in V1 and a W shape in V6, then this is right bundle branch block, and this can be seen from right heart strain, such as a PE, cor pulmonale, and ischemia. Now looking at the ST segment. Depression of the ST segment from the normal waveform represents ischemia, and this can be impending damage to the heart. Elevation of the ST segment represents infarction, and the area on the ECG that this is seen in can correlate to which vessel of the heart that there is a blockage in, as depicted in the ECG here. Now we want to look at T waves. T waves are abnormal if they are inverted in leads 1, 2 and in V4 to V6. T waves can be peaked in hyperkalemia and they can be flattened in hypokalemia. Now we're going to run through some examples of some ECGs in clinical scenarios. So it's important to remember the steps and to refer to this slide if you're not sure how to interpret it. So first of all, we'll look at this ECG. As you can see, this is a normal ECG. The rate's approximately 75 beats per minute. This is a regular rate. The axis is not deviated. There are P waves present and they are before every QRS complex. The PR interval is not prolonged. The QRS is narrow and normal. There is no bundle branch block, there is no ST segment elevation, and there are no T wave abnormalities. So now we'll move on to some abnormal ECGs and use our systematic approach to identify the abnormality. So in this ECG here, we can see ST elevation present in leads V1 to V6 and in leads 1 and AVL. Corresponding to this, we can see that there is ST depression in the inferior leads. This represents reciprocal depression. Therefore, overall, this is an acute anterior MI, which is most likely to be affecting the left anterior descending artery. Moving on to this ECG now. We can see that this is irregularly irregular, and there are no P waves present. So automatically this screams at us that this is atrial fibrillation. In this example here, it's important to try and identify where the P waves are and their relationship to the QRS to help you here. The best place to look for this is in the rhythm strip along the bottom, which is an extension of lead 2. So here we can see where the P waves are, and we can see that there's no association between the P waves and the QRS complexes. This represents to us that this is a third degree or a complete heart block. Moving on to this ECG. This is an ECG that, yes, you can use your systematic approach, but it's about pattern recognition and realising that this is a serious ECG. There are no identifiable QRS and P waves, and there's a bizarre, irregular and random waveform. This represents ventricular fibrillation. Moving on to this ECG, it's really important to use a systematic approach here because the changes here can be quite subtle to see. So what we see here is an M shape in V1 and a W shape in V6. Therefore, this represents right bundle branch block, showing that there is strain on the right side of the heart. In this example here, we can see that there are tall tented T waves, a wide QRS complex, and small or absent P waves. Therefore, this would tell us that this patient potentially has a hyperkalemia, and it's important to check their potassium, as they will need treatment. This example was put in to show a classically described ECG in the case of pulmonary embolism. You see this pattern of S1, Q3, T3 very rarely, but it's what is described. So there is deep S waves in leads 1, there is a Q wave present in lead 3, and there's an inverted T wave also in lead 3. However, more common findings to see in acute pulmonary embolism include sinus tachycardia, right bundle branch block, right axis deviation, and atrial fibrillation, as we have already covered in this talk. So that concludes the talk on ECGs. I hope that you found it useful. Thanks.